All right, everyone. Welcome to Brain Health with Dr. Nissen. I'm here with Dr. Rodrigo Mansur, and we are here to talk about the relationship between metabolism or metabolic illness and inflammation and mental illness and mental health. So the importance of kind of how we eat, our diet and exercise, and our blood sugar control, our fat metabolism, and how all of those things relate to risks for developing mental illnesses. So I hope that you will all have some takeaways from this conversation that will hopefully go beyond just your doctor telling you, oh, you should try to lose weight or you should try to avoid sugar and candy. Hopefully you can understand why some of these things are important. So without further ado, here's Dr. Mansur.
Pleasure to be here. Thanks again for the invitation and for the opportunity to talk more about our work.
Yeah, of course. So would you mind giving everyone just a little bit of background about you and the work that you do?
Sure. So I'm a psychiatrist. I'm a clinician scientist here at the University of Toronto. I'm Brazilian by background. I did my medical degree and my residency in psychiatry back in Brazil, and then I've been the past decade here in Toronto developing this research work on the interface between metabolic conditions and mental health issues, specifically mood disorders, which is our area of specialty. So I started working on this area in my residency, initially more from a clinical perspective, so looking at the effect of comorbid medical conditions on the illness course and characteristics in people with bipolar disorder initially. So the idea was basically to look at the differences between people with bipolar disorder that were obese and people that were not obese. What that meant in terms of how severe the illness were, how complicated it were, how it affected some of the underlying neurobiological characteristics, how it affected the treatment response. And that kind of line of inquiry evolved to what I've been trying to do more recently, which is to more investigate these as potential causes, right? So we know that the presence of metabolic comorbidities can greatly impact the course of mental health issues. But the question we are moving now today is, what does that mean from a cause and mechanism point of view? And also a lot of what we do is try to translate that into clinical applications and, broadly speaking, treatments. So using this knowledge, these things we learn about this interaction between mood and metabolic conditions, to hopefully develop novel treatments, different treatments than the standard ones we have available today.
Yeah. Well, for everyone listening, I think that this area is so important because, for a very long time, mental illnesses have had the stigma of being at, this mind-body duality, that we have our bodies that can get sick, but our mind is, our own responsibility. And we're always in control of, the thoughts that we're having, the behaviors that we're having, and, these illnesses, like you're showing, have a strong biological basis to them, and our bodies, how healthy our bodies are, plays a role in our ability to develop a serious mental illness. And specifically, the brain is an organ, right? It can be it just like your liver can get an infection, or it can become inflamed, and it can lead to all sorts of symptoms across your body. Your brain as well can become inflamed and could have an infection, or could have problems with processing different food sources, and it can create all sorts of problems. So hopefully, one takeaway everyone will have from this conversation is that, the brain is an organ just like any other organ in the body, and it can become sick. And our understanding of the body and of the brain will help us to, in our approach to the treatment of mental illnesses.
For sure. And there are all these analogies about how the human brain functions. And a very popular one is seeing the brain as a computer. But one of the main differences of the brain and a computer is that the brain has a body, right? It is deeply interconnected to the body. It has attend to the needs of the body from a basic physiological perspective, and is also very responsive to what's happening in this body, both from a health as well as an illness perspective there. So yeah, the key takeaway message is that there is no distinction between physical and mental health, right? These are all the sides of the same coin in many important ways.
Yeah. Well, something that I'd like for us to begin talking about is metabolic illness. What is meant by that? What is metabolism and metabolic illness?
So when we talk about metabolism, generally we are referring to energy metabolism, which are the processes involved in obtaining, transforming, and using energy resources to sustain body and brain function. The illnesses that affect energy metabolism, again, they're very broad, but generally we are thinking about the primary metabolic illnesses like obesity, diabetes, both type 1 and type 2, and metabolic syndrome, which is less of an illness itself and more like a constellation of different problems affecting both glucose regulation, lipid regulation, blood pressures, and so on. And these are conditions in themselves and are important risk factors, right? There's this debate of how much obesity is really like a medical condition, especially as these in themselves are very heterogeneous, right? You can develop obesity on as a result of a dozen, if not more, different pathways. These are also complex conditions in itself. They involve different neurobiological pathways, but also very responsive to environment and environmental changes. They are, however, connected with a series of relevant outcomes, both social and health-related outcomes. So the reason why sometimes we talk about obesity as a disease, even though it might not be as much of a disease, or at least has the same classical characteristics of defined disease, but we sometimes talk as such is because it is such an important risk factor for a number of other conditions. For example, cardiovascular disease, obesity is one of the main risk factors for.
Yeah, one thing that I wanted to point out, so, you were talking about energy metabolism. I think some people don't fully know or understand how the body uses energy and where it gets it from. I think everyone realizes it comes from food, right? And food can be broken down into things that can be used in the body for energy. And one way that food is broken down is in carbohydrates being broken down to sugar molecules. So, in somebody that's eating, a diet rich in carbohydrates, your body's going to be utilizing the glucose as a fuel source to power the brain and power your muscles and things like that. There are some other fuel sources that exist other than glucose, and so fat breakdown and ketones. People that have heard of ketogenic diets. That is when fat is broken down and you have ketones that can be used by different organs in the body as an energy source. And then, those are the primary two that come to mind. When proteins are broken down that through another mechanism are turned into a sugar. So those are some of the energy sources that Rodrigo is referring to. Anything that you wanted to add there?
Some of the basic principles there is that glucose is the preferred fuel for neurons. And neurons have a very high demand for glucose. One of the reasons why psychiatry ourselves are so interested in this area is because of the very elevated energy demand of the brain. So the human brain is about 2% of the body mass, but it consumes between 20 and 25% of the available energy resources. And the reasons why the brain is consuming so much energy is to support what is thought as kind of the higher order functions there. What really consumes energy in the brain are connections, neuronal connections, sustaining and building long-term connections, which are thought to be kind of the underpinning for cognitive function. So the things that make the human brain unique and special in many ways, or at least we think, right, are the factors driving this elevated demand for energy resources. Going from the functions that are affected in mental health to the functions that are also deeply interconnected with energy metabolism, there is a clear connection, which is an interesting thread for research. And indeed, the neuron has this preference for glucose, but it's not exclusively, so it can process ketone bodies, but in very specific conditions, right? Which is one of the key tenets of the ketogenic diet, is that you have to have also a low carbohydrate diet. Because if you have normal carbohydrates, that's going to be the preference. You can eat as much ketone bodies or have access to much ketone bodies as you want. If there is glucose, that's going to be the brain preference. And this isn't only about the fuel in a way. There are important differences in how these molecules are processed, and these are going to affect a lot of secondary mechanisms, signaling mechanisms that comes in the way that the brain is processing and perceiving the availability of energy.
So kind of taking a step back to the initial question, what is meant by metabolic illness? We're talking about an illness or difficulties or problems with metabolism, which is energy, utilization, consumption in the body. So, a common, metabolic illness that people have heard of would be diabetes, and that is because you have an illness, you have a problem with the utilization of glucose, sugar, as an energy source. So that's an example of a metabolic illness. Next thing I wanted to move on to is inflammation. This is something else that we're going to talk about during this chat. What is meant by inflammation, and as you study it, how specifically do you look for markers of inflammation in the body?
So the immune inflammatory system is the system that protects the organism against infections, and is also deeply involved in the response to injuries of all kinds. The classic way we study it is by looking at markers. This can be body-based or blood-based biomarkers, for example, that indicate the level of inflammatory response. You can look at that during, let's say, rest or during static conditions, or you can also do challenges. For example, there is a classic paradigm in neuroinflammation where you inject the subject with lipopolysaccharide, LPS, which is a pro-inflammatory changes, and the body interpreted that as a kind of like a infection challenge of some kind, and then responds with the pro-inflammatory response, and then you can measure all kind of mediators. And from a physiological perspective, inflammation and energy metabolism are deeply intertwined as well. There are different nodes where the systems crisscross. A classic one being the insulin receptor. We talked a little bit about diabetes, right? Diabetes is as much an unit of insulin regulation. You can have either insulin deficiency because of problems in the pancreatic production of insulin, but you can also have insulin resistance. Either your muscle or your liver is not processing insulin, therefore it's not, these tissues are not absorbing glucose, and that results in elevated blood glucose. And the insulin receptor can be affected by a number of mediators, very much including inflammatory mediators. So there's this molecule called TNF-alpha, which is one of the classical markers of inflammation. It's a pro-inflammatory cytokine. This is known to deactivate the insulin receptor, so making that specific tissue insulin resistance. There are more points where the systems cross, so accumulation of adipose tissue is also known to lead to the production of inflammatory cytokines, either directly or indirectly due to secondary injuries. But usually these are very connected systems.
So, I do think for people listening that maybe don't have a good understanding of insulin and glucose, one way that I've sort of described it to patients before is you can think of your cell like a furnace, and glucose is like wood. And insulin is sort of like the key that opens the furnace door into the cell. And so, if you have diabetes or any amount of insulin resistance, you have problems with your key opening the door so that the wood can get into the furnace and be burnt off. And so, since you can't get the wood into the furnace, there's problems with the furnace, your cell function on one side, but then on the other side you have all this wood building up that's in your bloodstream, and that creates all sorts of problems. How specifically, though, does that particular problem of insulin resistance, how does that relate to inflammation?
They are, I would say, closely correlated, although in many important ways separate constructs. They physiologically mean different things because the inflammatory system and the insulin system, they also serve different functions, right? Which is a challenge from a research perspective, because as these are closely correlated, you have to make an effort, because a lot of the scientific method is about trying to isolate as much as you possibly can certain systems of interest so you can fully understand it, right? If you look at the forest, right, you're just kind of seeing this mass of trees, and you have a hard time really understanding what's going on beneath them, what's going on in the ground there, all the complexity between the living organisms there, how they interact with each other. So a lot of what we do sometimes is try to isolate so we can understand it, even though there are some inherent limitations to that, because in the living organism, right, these are interacting, they are supposed to be interacting. This is how the systems talk to each other, and this is how they adapt to changing circumstances, both internal and external.
Yep. Well, taking a step back to the initial question of what is meant by inflammation, as you had described it, it's our body's immune system, basically making preparations to fight an invader. So if we have an infection, then there will be an inflammatory response to that in order to prepare to fight. But also, inflammation can go up for a variety of other reasons other than an infection. So some of the, I guess one thing I'd like to mention is some of the byproducts of breaking down food can create sort of a spike in some of the inflammation. There can be reactive oxygen species that are released from the breakdown of food, of energy sources in the body, specifically if you had something like lipopolysaccharides, like you mentioned, either found in your body from an infection or just injected into somebody, it can increase their inflammatory markers, and that may have implications for risk for mental illness. So let's kind of talk about that next. What are some of the things that you've found both in your research but also just in your expertise area and your reading about the relationship between these two things of metabolism and inflammation and the risk for specific mental illnesses?
Well, it is well known by now, and I think it's something that most clinicians or healthcare professionals can observe in their daily clinical practice, of how common metabolic conditions is in people with mental health issues, right? We see the prevalences of obesity, type 2 diabetes, metabolic syndrome are very elevated, and that has a series of important implications. One that I find that can be sometimes neglected is just mortality, right? We know that it is a tragedy, but it's unfortunately true that people with mental illnesses have a lower life expectancy than the general population. Depending on the illness, depending on the country, there it can be up to 15 years, which is very, very significant. And when you look at the causes of this premature mortality, the number one cause by far is cardiovascular disease. Suicide is, of course, what comes to mind when you think about mortality in mental health. And, of course, suicide is an incredibly important issue, a public health emergency in many ways. But, again, the number one cause of death in people with depression, bipolar disorder, psychosis, is cardiovascular disease. And that's driven by a number of different factors. It's driven by lower levels of physical activity. It is driven by higher rates of smoking, but it's also very much driven by these very elevated rates of obesity, diabetes, and metabolic syndrome. So there is a kind of clear clinical need to identify and manage those problems. These issues also have impact directly on mental health, right? On the signs and symptoms of mental health and how mental health issues tend to progress when there is a comorbid metabolic condition of those kinds. So we know, for example, that someone that has depression and obesity, they tend to usually to have worse symptoms overall. They tend to have a few specific symptoms in a more intense way. Cognitive symptoms are very common in depression in general, so problems with focus, attention, concentration, memory. We know that these tend to be more intense when there is obesity or diabetes with it. Issues with motivation, and so anhedonia, which is one of the core symptoms of depression, so lack of motivation, loss of pleasure and interests. These also tend to be more intense. We have evidence, we have studies showing that these are more prominent in people with depression or bipolar disorder as well that have a comorbid metabolic condition. And also, the combination usually results in worse responses to treatment. So traditional treatments, antidepressants specifically, they don't work as well when someone has obesity and diabetes with their depression. Again, for a variety of reasons there, but there's usually just worse overall results.
That's an important point there is the, aside from all of the challenges faced by people with metabolic illness and mental health problems, very specific, very common one is antidepressants not working as effectively for people with metabolic illness and or for people with elevated inflammation. I'm aware of the work of Andrew Miller, who's at Emory in this area, and I don't know actually if they've published it yet, but I think they were doing a trial looking at instead of giving serotonergic antidepressants to give dopaminergic antidepressants to people with, it was either people with elevated inflammation or with elevated sort of metabolic markers. But are you aware of some of that work, or would you mind kind of speaking about that specific issue?
There's very interesting work there, because again, I think that problem, you can look at that very different angles, right? But one interesting one is the why, right? Why are people that have depression and obesity do poorly on antidepressants? What is exactly happening in this combination or leading to this combination that is also affecting how they do with a serotonergic agent? One of the potential connecting threads is inflammation, because the activation of inflammation that can come from having a comorbid metabolic illness can also affect the monoamine system, can deplete serotonin, can deplete dopamine levels. Hence the idea of, let's use treatments more focused on restoring dopamine function to treat this. These are, I would say, very, very interesting ongoing efforts. There are also efforts trying to maybe go to treatments more on the metabolic side, which is something that we are doing currently. Trying to use quote-unquote metabolic agents to treat mental health issues. So anti-diabetic agents, weight loss agents. There are a few studies looking at medications such as pioglitazone, which is a medication used for diabetes. And some of the studies have found that they have antidepressant effects. There is interesting as well in this newer class of antidepressant medications, the GLP-1 receptor agonists, which also have been used successfully recently for the treatment of obesity. These are very effective weight loss agents like liraglutide, semaglutide. And we have a study going on currently here in Toronto using semaglutide to treat the cognitive symptoms of depression. Our angle being that because cognition is more affected in people that have depression or obesity, it may be an interesting target for a metabolic approach. So our trial right now is testing if this drug used for weight loss can improve the cognitive function of people with depression.
And is the population in the trial people that do have insulin resistance
they have
or
they
obesity?
Have to be overweight.
Overweight. Okay.
There's an issue with definitions in the field, and there's an issue with definitions in the whole psychiatry, but particularly when you go to metabolic side, right, you have different metrics. You can use body weight, which is useful but very imprecise in many important ways. You can use body fat percentage, again, a little bit more precise, but then a bit harder to measure, not hard to measure, but then you need specialized equipment to do it. You can use insulin resistance, but then you need to do blood work. So compromise solution here is to use something that it's easy to measure, and there are at least agreements about what it means. We know that BMI is a very precise measure of general metabolic health, but it's one that has been used widely. So more or less people understand what it means, so it can be useful to really apply to a clinical study like ours.
Yeah, so, just for the listeners out there, there's been some evidence of treatments for blood glucose issues and for metabolic illnesses being treatments alone for mental illnesses. So you mentioned pioglitazone. That's a medication that's been used for diabetes for a while. And correct me if I'm wrong, but I think actually some of the studies have found its effects in populations that don't have diabetes or insulin resistance.
What I'm talking about here are studies looking at non-diabetic populations. It's using these drugs for people that don't have diabetes but have depression. Because the combination is so common, you can sometimes look at specifically people that have both, but not always. Some study just kind of gave pioglitazone, for example, for people with depression and no diabetes, and found that it had an antidepressant effect.
Yeah. So pioglitazone and semaglutide, which is part of this new class of diabetes medications as well. And those are being looked at, I believe, also at this is maybe an aside that some people won't be interested in, but a big issue in psychiatry is the metabolic side effects of antipsychotic medications. And for a while, people have given metformin, which is a very common diabetes drug, to kind of help combat some of those effects. But semaglutide and liraglutide are new medications that may be good combinations with antipsychotic medications to reduce some of these.
And sure, the evidence on using metformin for that purpose is very good. Metformin is quite effective at preventing the weight gain that some, not all, but some medications used in psychiatry have, particularly the second generation antipsychotics and typical antipsychotics. They are quite often associated with weight gain, and metformin does a very good job managing that. So I do feel this has to be better known because it's a usable, safe, and effective strategy.
Yeah, absolutely. Well, so, again, stepping back and looking at this question, so the impacts of metabolism and inflammation on mental illness, people that are having issues of energy metabolism, so people that have insulin resistance or diabetes, or people that have obesity or blood lipid problems, maybe at higher risks of mental illnesses developing. One thing that I did want to define there of insulin resistance. So again, insulin is sort of the key opening the door of the furnace so that you can put the firewood into the furnace. That's one way that's looked at is with hemoglobin A1C, which probably a lot of people have heard of. It's something your doctor will monitor, and the cutoff for diabetes for type 2 diabetes would be 6.5. But what a lot of people don't know is that there is pre-diabetes, and that is still alarming, and it's indicative of some problem with insulin and glucose metabolism, right? And so the cutoff for that is 5.7. which, at least for me, when I, check hemoglobin A1C on patients, maybe, a good amount of them don't have unknown diabetes, but a good chunk of them do have undiagnosed prediabetes. Yeah. And so, it's something to talk with your doctor about, see what your hemoglobin A1C is. And if it's 5.7 or above, that's, it's showing that you have prediabetes. It's heading in that direction, and you have some problem with your metabolism. It is often a precursor, right? It's
a good predictor of the eventual development of diabetes. So it is a point where you should start doing something about it, not necessarily going to the medication route, probably not, but at least already start doing dietary modifications, exercise programs, some sort of integration, because it's a sign that if left unattended, there is a decent chance of this progressing to actual full-blown diabetes.
Yep. And a takeaway, I think, of everything that Rodrigo's been saying is that if you are somebody that's taking medications, particularly an antidepressant, and you either have obesity or you have insulin resistance, so hemoglobin A1C, above 5.7 or definitely if above 6.5, if your antidepressant isn't working, maybe there's a role that your metabolism and or inflammatory response is having in your kind of lack of response to these medications. So it's something to keep an eye out for. So any other thoughts here about metabolism, inflammation, and risk of mental illness? In particular, I know we didn't mention kind of cognitive. I mean, there's some mention of the cognitive effects of metabolism problems. Looking at even illnesses like Alzheimer's or Parkinson's disease, there may be a relationship here. Is there anything that we could discuss about?
I think you were saying earlier about about the role of insulin, and that was a very interesting analogy. But it should be noticed that the brain insulin system does work a bit different than the periphery. So the brain is mostly an insulin, or the brain mostly doesn't require insulin to absorb glucose. It does so independently. But still, insulin has very important roles for normal brain function. So we know that there are plenty of insulin receptors in the brain, and that they are involved in roles beyond just metabolism or just appetite regulation, for example. We know that insulin receptors are involved in memory formation, so manipulation. We know that, for example, from animal studies, that manipulating brain insulin receptors can affect the formation of memory. There's also evidence indicating that insulin receptors in the brain are involved in the regulation of motivation. There is a very important crosstalk between insulin and dopamine, which is talked a little bit before, is kind of this key neurotransmitter of motivation. It is sometimes talked about as the pleasure neurotransmitter, or more precisely, the reward neurotransmitter. And we also know that dopamine has very important effects on energy expenditure, which is, I find to be sometimes the missing piece in the talk about metabolism. Usually when we talk about metabolism in psychiatry, we focus on the energy intake side of the equation. So about nutrition, about what we put in our bodies, which no question is extremely interesting, right? But energy balance has the other side of the equation, which is energy expenditure, which is partially about physical activity, or like volitional physical activity, but there are a few other very important components. Basal metabolic rate, which is kind of just the basal rate that our body consumes energy to sustain our organism function. You have thermogenesis, right? So how your brain reacts to different temperatures, which is interesting in itself, but also can be manipulated for therapeutic purposes as well. There is this whole side of the equation which is relatively underexplored in psychiatry, right? I think we have this concept that maybe people with mental health issues are not as physically active, which is in many important ways true. But why exactly? What is precluding them from being more physically active? There are big gaps there. which can limit how we can use that, right? Physical activity has been talked about as a treatment for mental health issues, with good reason. The evidence there is usually pretty good. But on a clinical practice, that can be hard to apply, right? We usually tell patients all the time that you should exercise more, but we rarely go beyond that in terms of trying to identify the reasons why patients are not exercising, what are the obstacles there, working with them to kind of facilitate programs. I think we still have a long way to go there.
Absolutely. Well, thinking about, in particular, how glucose is used as an energy source in the brain, and thinking about Alzheimer's disease, which doesn't always fall within the range of perhaps psychiatry and psychiatry research, but there's been some interesting studies looking at glucose metabolism in brains with Alzheimer's disease, and the use of other fuel sources, specifically of using ketones as an energy source in people with Alzheimer's disease. And this is maybe taking us in kind of a different direction here, but people can think of ketones as possibly being another fuel source that can be used to allow the cells to function and have energy in a brain with Alzheimer's disease, rather than glucose, since there is some evidence of an Alzheimer's disease of those brains having more difficulty using glucose as a fuel source to have the brain functioning at kind of full RPMs like would happen in a normal brain. Yep. But it's an area of research, and it's not very clear. I mean, there's been some smaller. I remember there's this one small study that was looking at coconut oil, which does have higher level of medium chain triglycerides as a possible intervention in Alzheimer's. Like you mentioned, though, if somebody is trying to use ketones as a fuel source, there would need to be a lack of carbohydrates in their diet in order for that to happen. But it is something that I know has been looked at specifically for Alzheimer's disease, and perhaps something that you're more aware of is how these things have been looked at.
This is also
in
a
other
very
mental
active
illnesses.
area of research, both the role of insulin resistance and just general brain glucose metabolism in neurodegeneration. And it is a classic finding in Alzheimer's that brain glucose uptake tends to decrease it with illness progression, and that's usually correlated with symptoms, with cognitive function, which is one of the inspirations for our team and others to look at cognition in the depression population and try to address it through the metabolic side, even though some of the mechanisms are obviously quite different from Alzheimer's or from dementia. And there is also great interest in using just dietary manipulations in general, particularly the ketogenic diet, both in Alzheimer's and now more recently, I think this burgeoning interest in mental health. And there is a lot of interesting findings. I think it's an idea that makes sense. One of the things about the preference of neurons for glucose is that neurons tend to process glucose in an anaerobic way, which makes sense because it's a way to kind of produce ATP, which is the molecule the cells use to power its functions. The anaerobic route produces the ATP faster, which is necessary for neurons, as they need to respond fast to changes. But that tends to be more inefficient in many ways, and that leads to the production of reactive species, which is what we usually mean by oxidative stress, for example. And these, if not attended to, if not controlled, it can lead to the damage of the neuron on the cell. And that's less of a problem with ketone bodies, right? If you can switch the energy matrix from glucose to ketone bodies, you have less production of these oxidative species, and therefore it leads to less long-term damage to the neurons. So there is kind of a sensible, consistent neurobiological story there that makes sense. Yeah,
and even from a step back, the idea behind this at least, so Chris Palmer is a researcher here at Harvard Medical School who was, kind of thinking about how ketogenic diets were used in epilepsy and have long been used as a treatment in epilepsy and, so for seizure disorders. And there's a lot of similarities between seizure disorders and bipolar disorder, particularly, but a lot of other psychiatric illnesses, a lot of crossover. So the idea was, well, would a ketogenic diet, which has been useful for the prevention of seizures, would it be useful for the prevention of manic episodes in bipolar disorder? We use the same kind of medications. We use anticonvulsant medications for the prevention or for mood stabilization. And so would using a ketogenic diet possibly have those same effects? And that's been an interesting area of research.
It's definitely very interesting. The caveat, and there's always a caveat when it comes to research in psychiatry, is that we need good quality evidence, right? Psychiatry's history is full of very sensible, intuitive, if not obvious ideas that never worked out for a variety of reasons, right? I think a very good example, we were talking earlier about monoamines, right? There was this idea that, depression was caused by a monoamine deficiency, which 30 years ago made perfect sense. Like you had monoamine drugs that treat depression. So if you have a drug that increases serotonin and treats depression, that means depression must be a lack of serotonin. And that's not true. So it's psychiatry's history full of stories like that. So from a very sensitive and reasonable idea to actually proving that there is a long way to go. And when it comes to diet, or dietary interventions, we really need studies, right? And preferably we need controlled studies, which is a challenge in dietary interventions. It's really hard to blind a dietary intervention. It's not impossible, but it is hard to blind. And you need to blind because, of course, every kind of intervention will come with expectation effects, it comes with placebo effects. And placebo effects can be very positive from a clinical perspective, but for research and scientists, they need to be accounted for, right? So I think there is an urgent need there for good quality control studies in dietary intervention so that they can be truly validated. I mean, we have to show that they work for mental health issues, and we don't have that yet. And as importantly, we also need to learn if they do work, how do they work, right? What are the mechanisms behind it? So we can use that to maybe translate into other types of treatments, maybe mimic their effects in other ways. Ketogenic diet is a good example of an intervention that seems very interesting, but also can be very hard to apply, right? It can be very difficult. I have patients that have tried to do it. Some patients succeeded and did great, but some patients found it really, really hard to do it for longer than, let's say, just a few weeks. So for those people that can do it, either because they find it hard to adhere, or because there's also a social aspect here. It can be a more expensive diet. It can be a diet that's not readily available everywhere in the world. And when you talk about interventions for mental health issues, you need to think about scaling because, for example, depression is extremely common, right? So you need to think about interventions that can be easily applied for millions of people all over the world, both low-income and middle-income areas. So if you have someone that cannot apply the diet for any reason, what else can we offer them that at least is going to be on those lines, or use similar principles, or target that specific neurological pathway that the ketogenic diet would or might address? Right.
Well, to kind of wrap up our conversation, what do you think would be the takeaways from everything that you've, learned and have researched on, for the average person perhaps struggling with depression that hasn't gotten better with multiple treatments, and maybe they're a little bit overweight? What do you think would be, what would you hope for their, takeaways to be from this conversation?
The recommendation
and what might be
is
helpful
to care
for them?
For yourself, right, and to care for your physical health. Mostly through, I would say, initially common sense approaches, right? We talked about these very interesting novel interventions, but some of them are not, let's say, ready for prime time or ready for regular clinical practice, including semaglutide, which is like my area of study here. It's not something that I recommend to be used routinely because we don't know enough about it yet. We do know, however, that like common sense dietary approaches. It doesn't have to be a ketogenic diet, but a more balanced diet that can go a long way in improving physical health. Physical activity has this tremendously positive, varied positive health outcomes, not just physical health, but it has these antidepressant effects. As we talked before, we sometimes need to go through the effort there of trying to figure out what are the obstacles for people exercising more, rather than just prescribing in a way do more. But for people that are suffering from it, the effort towards doing more again doesn't have to be anything extreme. And an important concept in physical exercise is that also there is no single best modality. Right? Sometimes people try to find what's going to be the quote-unquote magic pill in terms of exercise, if it's going to be weightlifting, if it's going to be hot yoga or something. But the truth is that it's going to be personalized, right? It has to be something that people either enjoy it or at least can tolerate, and as importantly, can fit into their schedules. Because, of course, the benefits of exercise only come if you're doing regularly over long periods of time. Right? So I can tell you the best exercise in the world is to swim, but if you hate swimming or if you don't have a pool nearby, what's the point, right? But find something that can be done regularly, can be fit into schedules. That can also go a long way in terms of helping everyone's mental health.
Yeah. Well, so that's a really good point, and I heard a quote that kind of sums up what you said, which is, what's the best exercise? Yeah. Whatever one you can do regularly, right? And so it could be walking, if you can tolerate something a bit more, what's the word, sort of intense, doing a regular jog or run or regular weightlifting. All of them have their own benefits. Yeah. Swimming, like you mentioned, playing sports. To try to do something like that and make it part of your sort of daily routine, that can be really helpful. You mentioned taking care of yourself nutritionally, and so we mentioned a ketogenic diet, but there are so many different diets, and the one that's been very widely researched, but I think is still kind of difficult to understand, is the Mediterranean diet. There's a lot of evidence that a Mediterranean diet is perhaps the quote-unquote healthiest diet, but it's defined in different ways in different studies. And I think when I say to patients, try to eat a Mediterranean diet, they're like, what does that mean? So I'll tell you what I say to people, and I'm kind of curious what you would change or add or correct. But I normally first I educate people on what carbohydrates are. So that includes sugar, like desserts, candies, sugar. A very, very important source of sugar is in beverages. People consume tons of sugar in their beverages. So that's soda, that's not diet, but also juice. Juice, a lot of people think is healthy, but if you're drinking, just straight up apple juice or orange juice, you're getting tons of sugar through that. And drinking it kind of increases how quickly it gets into your bloodstream. So anyways, identify those sources of sugar, but then other carbohydrate sources are things like rice, pasta, potatoes, bread, things like that. So identify what those things are in your diet and try to reduce those. I think just about everyone can benefit from some degree of carbohydrate reduction. You don't have to have a ketogenic diet, but to have a plate, if you have a plate every day of rice with some sort of meat on top of it, and then a glass of orange juice, to get rid of the glass of orange juice and trade it for maybe whole oranges and a glass of water, and to decrease the amount of rice you have on the bottom, or if you do have a blood sugar problem, to get rid of the rice entirely and put the meat on top of a bed of like greens or something like that. That will really make a big difference.
Right? To your point, you don't have to completely eliminate one food or the other. Actually, you shouldn't, right? It's always about trying to find a good balance there. And try as much as possible as well. Try to keep some level of enjoyment, because the kind of pleasurable dimension of eating that can be quite important as well. So
Right.
it is not like when you talk about managing your diet to treat depression, that means you cannot ever eat pizza or fried chicken. Of course you can, and you can still should be able to enjoy it. Of course, if you make all of your meals that's going to is normal, it will be the problem. But to strive to keep at least a level of enjoyment, because that's important to maintaining, sustaining long-term health diet.
Absolutely. I think something that some people have found helpful is to try to enact your dietary goals in your day-to-day eating at home. So try to cook healthy at home. But then when you go out to eat, order whatever the heck you want. And, if you're going out to eat once or twice a week, for, just 1 or 2 meals a week, it's going to make a big difference to make those huge changes in your home cooking. But then you can still, go out and eat whatever thing you wanted. Sometimes that helps people, so you feel like they're not suffering 100%
it can be
of the
like,
time.
And like we are all
as they're making
bombarded
the
by
changes.
information about our diets constantly, right? So it can be overwhelming, right? And again,
Right.
that doesn't make it unimportant as an issue to be aware of and for us to discuss with patients. But yeah, I think we need to dial the tone there as well, so it doesn't kind of become a chore. It doesn't take away completely the pleasurable aspect of it.
Yeah. And I hope that one other takeaway for people here is if you have a mental illness and you're not satisfied with the treatment of your mental illness, think about your risk factors for metabolic illness or elevated inflammation. And you can talk with your primary care doctor and your psychiatrist about that, and to think about whether or not those things might be somewhat contributing to some of the resistance that you're having to the medications. I think for some people it can give some clarity of that. That's why I've tried a ton of different antidepressants and haven't felt better, and it can give you a new motivation for reaching some weight loss goals or things like that as well. So I hope that that's a takeaway from this conversation as well. All right, Rodrigo, any ways that people can learn more about you and your work, or any other messages that you wanted to leave the listeners with?
Mostly through scientific publications, which unfortunately are not as open as they should be, although that's a discussion for another day. People that are interested, we also have their information about myself and about our ongoing studies at the University of Toronto website. Our studies are all registered as well in public databases like clinicaltrials.gov, for example, where people can find information. But yeah, from my side, I think that's more or less where I am.
Great. Well, thank you so much for your time, Dr. Mansur. I really appreciate your experience, and I'll be looking forward to seeing kind of all the findings that you're having.
Thanks so much. That was a great conversation. I really enjoyed it, and I hope it was useful for anyone that's listening.